All right. Um, Thank you very much for that kind introduction. It is such an honor to be with all of you here today at the Nova Scotia Hospice and Palliative Care Association conference this year. And I wanted to start by sincerely thanking all of the organizers for allowing me to join you virtually. While I would have loved to be there in person, I'm truly grateful for the opportunity to connect with you in this way and still be a part of such an important gathering. And as was mentioned, I'm joining you today from Toronto. And while I'm not from Nova Scotia, I hope to offer a national lens while recognizing that incredible leaders and experts will be speaking after me to provide more insights. Next slide, please. It is important for us to begin by acknowledging the sacred land on which we are privileged to live and work. And as I'm joining you virtually today from the Greater Toronto Area, specifically from Mississauga, I recognize the land I come from to be the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. This land is now home to many diverse First Nations, Inuit, and Métis peoples. And I also want to recognize that this conference that we are all attending is taking place in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq, Wolastoqey, and Beskodew-Mogodi peoples. These are sovereign nations who hold inherent rights as the indigenous people, as the original peoples of this lands. And I offer these land acknowledgements not as a formality, but as a commitment to truth and reconciliation, and to working towards equity in palliative and seniors care for all. We are all deeply grateful to have the opportunity to live and work on these lands, but we must also remember that this is just the beginning. Truth and reconciliation is not a destination, but rather a lifelong journey. We must commit ourselves to ongoing listening, learning, unlearning, and the building of authentic, respectful relationships. Next slide, please. I would like to share my disclosures. So I do receive stipends or honoraria for work around leadership and education and program development. And I wanted to be clear that all of these relationships are based on shared values and collaborative work in the space of palliative care and health equity, working with not-for-profit organizations funded by different levels of government. Next slide, please. So today, I'm really excited to achieve a couple of very important goals with you. Number one, understand the importance of health equity, cultural safety, and anti-racism in seniors care, palliative care, as well as grief and bereavement. And number two, through 7 key takeaways, inspire this community to challenge themselves and their organizations to provide more equitable care. Next slide. I will start with a trigger warning. So during this presentation, I'll be talking about tough topics like racism, discrimination, and oppression. And I know that these discussions can be very hard, especially if you've experienced these things or if your loved ones have experienced these things. Also, if these conversations are new for you, you might hear ideas about power, privilege, and how resources are shared that you haven't thought about before. I want everyone who is listening to this talk today to know that each person's experiences are important. No one's experience should be dismissed as we work together to learn and grow. I also want to acknowledge that spaces and conversations such as these may not ever be fully safe for everyone. And I hope our aim can be instead to facilitate safer caring environments where we are all accountable for our actions. Our goal is to learn with and from each other, support each other, and to be mindful of how our words and actions affect those around us. Next slide. So let's start with a case today. This is the story of Imani. Imani is a 72-year-old woman who immigrated to Canada 18 years ago to join her family, and she now lives in a long-term care home after being diagnosed with advanced dementia and multiple other comorbidities, including diabetes and heart failure. Imani's family has faced systemic barriers throughout her care journey. They primarily speak Swahili and struggle to navigate the healthcare system, often feeling excluded from important discussions about Imani's care. Her son acts as her substitute decision maker, but frequently consults Imani's brother, who lives in Uganda. Imani's family and other community members bring in traditional herbal medicines and insist that they should be given to her along with her prescribed medications, which has led to tension with the staff in the long-term care home who are unsure how to integrate these medicines into her care and express concerns about potential drug interactions. Some staff in the long-term care home describe the family as difficult or unrealistic when Imani's son insists at care conferences that everything should be done to save her life, despite her clearly declining condition and the increasing burden of life-prolonging medical treatments. The care team in the long-term care home feels distress about the perceived futility of continuing aggressive treatments, but yet they struggle to engage in meaningful conversations with Imani's family due to cultural and language barriers. As a result, very unfortunately, mistrust has grown on both sides, with the family feeling that their values and beliefs are not being respected and the staff feeling frustrated and unsupported. Next slide. So as you can see, Imani's story highlights many different challenges. Her family feels excluded from care discussions due to language barriers, due to cultural barriers. Tensions are arising over the use of traditional medicines. The staff in the long-term care home have started to describe the family as difficult, which highlights implicit bias, a lack of cultural safety, a lack of a trauma-informed approach, and mistrust is growing on both sides, which is impacting Imani's quality of care and communication. Next slide. Okay, so rather than just reflecting on this case quietly, I'd love to hear from you directly. And one way that we can interact is by using these Slido polls. So please pull out your phone. There's a QR code in front of you on the screen, and maybe we'll give you about 30 seconds or so to scan the QR code. And the first poll, as you can see, that we have a reflection question in front of us right now. And I just want you to think of one word or a short phrase, whatever comes to mind first, about what's most important when integrating cultural beliefs into care. So we'll hope this works, but let's try. And in a moment, I'll ask Jordan to switch to the Slido poll. Okay, that's great. All right, so we see some great phrases coming up on the screen. Nothing about us without us. I really love that. Compassion, respect, listening, humility, listening to the family, humanity, caring, humility about implicit racism, self-determination. That's a really good one. Curiosity. I really enjoy whoever wrote that. Thank you so much. Being non-judgmental, having an open heart, assessment. All right, so let's move on to the next slide. If we can go back to the next slide. Thank you everyone for your reflections on what's most important. So now I want to briefly take a moment. Once again, this is another QR code and another question, so please keep your phones out. And I want to turn the spotlight on some of the challenges. So as we know, even with really strong values and good intentions, many of us actually do face real barriers when it comes to providing culturally safe care. So this next question asks you to consider, what do you think is the biggest barrier to providing culturally safe care in your setting? So once again, we'll give you a moment to scan the QR code, and then we'll switch to Slido. And I'll just add, while you're kind of putting in your answers, that you might feel, of course, that there's many barriers which will resonate with you. But I just wanted to generate some conversation around, perhaps the ones that you feel might be most pressing or impactful for you now. Okay, so we're seeing some responses around lack of diverse leadership or lived experience voices, lack of training or education, systemic or organizational barriers. And it seems like the top two are lack of diverse leadership or lived experience voices and lack of training and education. So I guess we can reflect on, there are some shared barriers that are there, and there might be some barriers that perhaps we can't even enter here that are not visible, to us. And these differences are part of why, culturally safe care actually takes more than awareness, and it requires system level change. So let's keep all of these barriers that are in front of you on the screen in mind as we move forward to the next section on how racism and oppression actually shapes care experiences and outcomes. So if we can please go back to the slide deck. Okay, so thank you once again for sharing your insights. And I just wanted to highlight that, of course, we started with this case about Imani, but Imani's story is not an isolated case. It reflects something much bigger, something that impacts countless people across Canada every day. And some of the barriers that you have named just now, whether it's a lack of training, systemic issues, time constraints, fear, they're not just individual challenges, but rather they are rooted in broader systems that have been shaped by colonialism, exclusion, and inequity. And this brings us to a truth we have to see clearly and without hesitation. Yes, racism does exist in Canada. It's not just a problem somewhere else, and it's not just a historical issue. It's here and it's now, and it shapes the care that people receive from diagnosis to decision making to the way that they are grieved after death. Next slide, please. So this slide highlights just a few key examples of how racism has been embedded in our very history, from the impacts of colonialism and genocide on Indigenous peoples to discriminatory immigration policies that excluded entire groups of people. And these historical injustices didn't just happen in the distant past, but they continue to echo in our healthcare systems today. For example, the legacy of residential schools has created deep mistrust in institutions, and exclusionary policies have left racialized communities with fewer resources and supports. So as we move forward, it's critical to recognize these histories so we can better understand how to dismantle the systemic barriers they've created. And as healthcare providers, we must be vigilant in recognizing how historical injustices contribute to ongoing inequities and advocate for policies that promote equity and inclusion. Next slide, please. Moving on to a brief discussion about the history of racism in healthcare, I want to share with you a couple of examples, and we'll start by talking a little bit about the legacy of William Osler, whose picture is in front of you on the screen. William Osler is a towering figure in Canadian medicine. He's been termed the father of modern medicine, and one of the best known physicians in the English speaking world by the turn of the century. That's what he was called. And many of the physical examination techniques that I learned in medical school were actually developed by William Osler. But while he's celebrated as the father of modern medicine, his legacy is also steeped in racism and colonial attitudes that shaped Canadian healthcare in harmful ways. So, for example, in a 1914 speech during the Komagata Maru incident, he publicly stated that Canada should be a white man's country. And this was a time when South Asian immigrants were actively being turned away at Canada's borders. He also mocked Indigenous peoples under a pseudonym, writing degrading comments like every primitive tribe retains some vile animal habit. He further participated in the shipment of Indigenous skulls from Canada to Germany, human remains that were treated as objects of scientific curiosity rather than with dignity and respect. And these actions and beliefs show how influential figures in medicine upheld systemic racism, legitimized harmful practices, and perpetuated attitudes that continue to persist in healthcare today. By acknowledging these truths, we can better understand how historical racism still shapes our systems and what we must do to dismantle it. Next slide. So this is pablum, a fortified cereal developed in the 1930s at Toronto's Hospital for Sick Children. It's often celebrated as a groundbreaking innovation in child nutrition. And in fact, my own mom tells me that when I was, of course, very small, she fed me pablum. But behind this success lies a troubling history tied to colonialism and racism in Canadian healthcare. And in fact, the research and testing that led to pablum was conducted on Indigenous children in residential schools without their consent and under unethical conditions. These children were already malnourished due to the poor conditions in the schools, making them vulnerable subjects for experimentation. And the pediatricians who developed pablum and who continued to conduct these experiments even after the Nuremberg trials in World War II spoke about administering colonial science because they viewed the bodies of Indigenous children as experimental materials and residential schools and Indigenous communities were viewed as kind of laboratories. So these examples, and many more which I do not have time to cover today, remind us that even celebrated achievements in medicine are not free from the stain of systemic racism, and rather they challenge us to rethink how we honor medical history and to confront many of the uncomfortable truths that continue to influence inequities in care today. Next slide. Now, you might feel that racism is just a historical phenomenon, something in the distant past, and not really too important to discuss today. However, this is not true. And I want to share with you just a few recent examples which highlight systemic inequities and experiences of racism within healthcare. So one example is the story of Joyce Echaquan. And Joyce's story is one of the most well-known examples of systemic racism in healthcare. Her death was widely publicized after she actually had to after she actually had to stream herself on Facebook Live receiving verbal abuse by hospital staff while she was dying of heart failure. And this sparked a national conversation about the urgent need to address racism in care settings. We have we can also look at the stories of people who are living with sickle cell disease, which predominantly affects Black communities. And patients with sickle cell often continue to face stigmatization, delayed care, and inadequate pain management. And this reflects broader issues of anti-Black racism in healthcare. And then we can go back to the earlier days of the COVID-19 pandemic, which highlighted ongoing systemic inequities with racialized communities disproportionately impacted. In many cities in Canada, there was a highlight on early failures to collect race-based data, inequitable access to tests and vaccines, which exposed gaps in care. Next slide, please. So a quick Google search using the term racism, healthcare in Canada highlights just how prevalent racism continues to be in our healthcare system today. And some of the headlines which I've put in front of you on the screen showcase a range of issues, from the lack of representation among healthcare leaders to anti-Black and anti-Indigenous racism, to the treatment of patients in emergency rooms, hospitals, and long-term care homes. Even the ways our system handles complaints about racism reveals systemic shortcomings. Some of these examples are overwhelming, and they do underscore that racism in healthcare isn't an isolated issue, but rather it continues to be deeply embedded in the fabric of our systems. And this slide serves as a reminder of why addressing racism in healthcare is not just important, but urgent. Next slide. So the bottom line here is that racialized communities are more likely to experience inequitable healthcare from the moment of birth through life, extending into end of life and into grief and bereavement. Next slide. So let's start by asking, how do we actually define racism and how does it manifest? This is a crucial question because defining racism isn't just about identifying individual prejudice, but rather it's about recognizing the systemic, institutional, and cultural dimensions that shape the world we live in. And as we answer this question, we'll uncover the layers and forms of racism that permeate healthcare and our society, and we'll think critically about how we can dismantle them. Next slide. Once again, racism is often understood as just racial prejudice, so negative attitudes or beliefs about a group of people based on their race. But prejudice alone doesn't equate to racism. And what turns prejudice into racism is power. Power allows these prejudices to become embedded in our systems, institutions, and policies. It's what enables discriminatory beliefs to shape laws, influence access to resources, and create inequities in healthcare outcomes. So in this equation, which you see in front of you on the screen, racial prejudice reflects the individual biases we may all hold, while power represents the structures and systems that allow those biases to have harmful effects. So for example, a prejudiced individual might hold stereotypes about a racialized group, but when that individual is part of a system like healthcare, law enforcement, or education, their bias, coupled with institutional power, can lead to outcomes like fewer job opportunities, disparities in treatment, or inequities in access to care. Understanding this dynamic is critical to addressing racism in healthcare because it's not just about challenging individual prejudice, but dismantling the systems that perpetuate inequity. Next slide. One way to understand how racism manifests is by looking at the distinction between overt and covert racism. So, overt racism, like hate crimes, racial slurs, or joining explicitly racist groups, is usually much less tolerated in society today. It's also more visible, obvious, and easier to condemn. Now, that said, I will acknowledge that in recent years, we have seen a resurgence of overt racism, especially with the rise of far-right extremism in many countries, including our own. Online spaces have become platforms for more openly racist and xenophobic content. And in some political circles, even right here in Canada, we're seeing a disturbing normalization of racist rhetoric. This trend emboldens individuals and groups to continue to express harmful views more publicly and with less fear of consequence. But for many, racism continues to operate in more insidious, everyday ways, and that's where covert racism comes in. And covert racism often flies under the radar because it's disguised as socially acceptable. And some examples include denying that racism is even a problem or that it exists, tokenism, tone policing, or blaming victims for their own oppression. And covert racism manifests in subtle but deeply impactful ways. So as you can see in the screen, as you can see on the screen in front of you, you can think of it as the base of an iceberg, hidden but far more pervasive and damaging. And covert racism continues to shape people's life opportunities, influencing who gets hired, who succeeds in education, and who is excluded from critical spaces. So these systemic inequities ultimately also contribute to healthcare outcomes, such as life expectancy, infant mortality, and access to and provision of essential services, such as long-term care and palliative care. And here's the overall critical point here. Social factors like racism often have a more profound impact on healthcare outcomes than access to healthcare itself. Racism doesn't just limit opportunity, but rather it directly impacts health, well-being, and survival. Next slide. So moving on, we can discuss the concept of implicit bias, which refers to the unconscious attitudes or stereotypes that influence our decisions and actions. So even if we believe we are being nice, caring, or objective, we definitely all have actually implicit bias, and these biases are pervasive and affect us regardless of our background or intentions. So why does this matter? In the healthcare system, implicit bias can lead to disparities in treatment, in diagnosis, and in care outcomes. And I'll share two key examples to illustrate this point. So many studies, and in fact, we have decades of research that shows that Black patients are less likely to receive adequate pain management, regardless of whether it's in in an ambulance, in the emergency room, in the ICU, in a palliative care setting. So that's an example of how implicit bias can impact healthcare outcomes. We also know that women are more likely to have their symptoms dismissed or misdiagnosed when they seek medical attention. They're more likely to instead be dismissed as being anxious and so on. So, the key takeaway here is that we have to acknowledge that this exists. And that's the first step to addressing these biases. And there are tools like the implicit association test, which has been developed by Harvard University, which is valuable for self-reflection and can help us uncover hidden biases so we can begin to change how we approach care. And, the graphic and the illustration on the screen in front of you is from Harvard University's implicit association test. Next slide. So how do we move from individual implicit bias to cumulative societal level impacts? The answer lies in structural racism. Structural racism is insidious, deeply woven into the fabric of our society, and affects every aspect of our life. It's the normalization and legitimization of an array of dynamics, historical, cultural, institutional, and interpersonal, that routinely advantage white people while producing chronic adverse outcomes for racialized communities. It's a system of hierarchy characterized by white supremacy, the preferential treatment, privilege, and power afforded to white people at the expense of Black, Indigenous, and other racially oppressed groups. Structural racism permeates everything: our history, our culture, politics, economics, and healthcare systems. And here's the critical point here: structural racism is the foundation. It's the most profound and pervasive form of racism, and all other forms, institutional, interpersonal, and internalized racism, emerge from it. And understanding this interplay is critical because it helps us recognize how deeply ingrained racism is and why addressing it requires systemic change in addition to individual actions. Next slide. So after discussing the definition of racism along with its different manifestations, I would like to focus on a classic and crucial discussion. Should we focus our conversations on race or on racism? Let's consider tuberculosis as an example. So in 2022, the rate of active TB among Inuit people was over 455 times higher than that of the Canadian-born non-Indigenous population. And for First Nations, the rate was over 71 times higher than that of the Canadian-born non-Indigenous population. And of course, these are staggering disparities, but they beg the question, why? It's not because Indigenous peoples have a genetic predisposition to TB. There's absolutely no biological reason for these numbers. Rather, the root cause of this inequity is racism, generations of systemic inequities, poor housing conditions, food insecurity, and inadequate access to healthcare, all fueled by structural racism. This demonstrates a fundamental truth. Race is not the inherent determinant of healthcare outcomes. Racism is. And this holds across all of healthcare, from primary care to acute care, long-term care, and palliative care. The disparities in outcomes for racialized communities stem not from who people are, but how they are treated and the systemic barriers that they face. Next slide. Now, I want to visit the concept of privilege because it's foundational to understanding equity and inclusion. So privilege refers to an unearned benefit or advantage that someone receives simply by the nature of their identity. It can operate on two levels: at a personal level, shaping everyday interactions and relationships, and at a systemic level, embedded in policies, institutions, and societal norms. And it's very important here, and I will emphasize this another time as well in my talk, that, I want to make an important distinction that having privilege in one area doesn't mean that someone hasn't faced any challenges or hardships in life. It simply means that certain aspects of their identity, such as race, gender, or socioeconomic status, haven't created additional barriers for them. So, for example, a white person may still struggle with poverty, but would be much less likely to face racial discrimination when seeking a job or accessing the healthcare system. And similarly, male privilege doesn't mean that men are free from all adversity, but it just means that their gender is very unlikely to have been a source of that adversity. Privilege is often invisible to those who hold it because it's woven into the fabric of everyday life. It feels like the normal or the default. And recognizing privilege, recognizing one's own privilege, is not about feeling guilty or laying blame or feeling ashamed, but rather it's about awareness and using that awareness to create equitable opportunities and advocate for systemic change. Next slide, please. Okay, so now that we've explored the concept of power and privilege, let's take a look at how these dynamics play out in more nuanced and interconnected ways. And at this point, it's crucial to recognize the concept of intersectionality, which has been developed through the work of Black feminist scholars like Dr. Kimberly Crenshaw, a lawyer, civil rights activist, and professor. Dr. Crenshaw's writings have been instrumental in shaping our understanding of how intersecting identities intersect to create systems of privilege for some, or discrimination and oppression for others. So one tool we can use to understand this concept of intersectionality is in front of you on the screen right now. It's called the Wheel of Power and Privilege, which illustrates how different aspects of our identity, such as race, gender, sexuality, and socioeconomic status, citizenship status, and so on, place us closer to or farther from societal power and privilege. So those near the center of the wheel hold identities traditionally associated with unearned privilege, while those at the outer edges are more likely to face systemic barriers, discrimination, and oppression. And once again, I will emphasize that privilege in one area doesn't negate discrimination in another. Some more examples of that. A white woman may face horrific gender-based discrimination, but would still benefit from racial privilege. Another example is that a wealthy racialized man may face racial discrimination, but still benefit from economic privilege. And this tool in front of you on the screen and the concept of intersectionality reminds us that privilege and oppression operates across multiple dimensions, shaping life experiences and healthcare outcomes. Next slide. Okay, actually, we'll skip this slide and move on to the next one. Thank you. Okay, so now that we've explored some of these broader concepts like racism, privilege, intersectionality, I want to bring this reflection back to your own work and ask you all a question. Are the healthcare outcomes of your patients or their loved ones affected by systemic racism or other forms of oppression? Once again, there's a QR code in front of you, and then we have a Slido poll that we'll switch to. We'll give you a few moments just to scan the QR code and answer. Okay. So I think we can see, some of the, we can pretty much see the responses, and it's affirming to see that many of us do recognize the truth, this truth. Systemic racism, colonialism, poverty, ableism, and other forms of oppression, these aren't abstract forces, but they do shape who gets access to care, how they're treated within the healthcare system, and even how long they live. And recognizing this is a crucial first step because it shifts the conversation away from blaming people for their own health outcomes, but rather towards transforming structures. For those who have said not sure or no, I just wanted to let you know that these perspectives are also important to acknowledge. Sometimes the most important thing we can do when we're learning is to pause and ask questions and perhaps be more aware to notice patterns that we might not have seen before. I'll also highlight here that sometimes inequity isn't visible until we start looking for it or until someone shares a lived experience that changes how we see how we see a particular situation. Okay, next slide, please. Okay, moving on, we're going to talk a little bit more about how racism manifests specifically in seniors care, palliative care, and grief and bereavement. So seniors care in Canada is not exempt from the inequities created by systemic racism. Racialized seniors are more likely to experience poverty, housing insecurity, and a lack of access to culturally appropriate long-term care homes. At least here in Ontario, only 8% of long-term care homes are designated as culturally appropriate. And this creates an environment where their needs are often overlooked and their care is inadequate. In long-term care homes specifically, many of the staff, the care teams that work in long-term care are usually women. More so in the cities, they're usually racialized women, often who don't speak English as their first language. And these people are overrepresented in caregiving roles, in frontline caregiving roles, but vastly underrepresented in leadership. So this disparity reinforces power imbalances and continues to contribute to systemic inequities. And we only have to look back to the earlier days of the COVID-19 pandemic back in 2020, when we know our long-term care sector was disproportionately impacted. And we saw, and data does reveal, how racialized seniors in long-term care were once again disproportionately impacted by a lack of adequate infection control and lower standards of care, which exposed the deep-rooted inequities in our healthcare system. Next slide. Okay, so how does racism affect palliative care? It doesn't just impact access to palliative care, but in fact, it can shape the entire experience of care for patients and their families. And these points on the slide highlight some of the ways in which systemic racism and cultural barriers intersect to create inequities in palliative care. So many patients and families may have beliefs or practices that differ from the dominant Western model of care. And we saw this in Imani's case, which I presented in the beginning. When these beliefs are misunderstood or dismissed by healthcare providers, it can lead to further mistrust or inadequate and inappropriate care. We know that historical and ongoing experiences of racism have created a deep mistrust in healthcare system among many racialized communities. And this mistrust can result in delayed care, refusal of services, or reluctance to engage with palliative care teams. So it's upon us as palliative care healthcare professionals to work very, very hard to build trust with communities. We know, and this is supported by data here, right here in Canada, that racialized communities are less likely to receive referrals to palliative care services. And there's also research that demonstrates that these disparities stem from systemic inequities, including biases in how healthcare providers perceive palliative care and how they prioritize care for racialized patients. Um, as you can see, the first point on the screen in front of you is about language barriers. There's a lot of data that supports how language concordant care, receiving care in the language that you are most proficient in and familiar with, would improve your healthcare outcomes. And that is definitely the case in palliative care as well. And we know that patients who don't speak English as their first language or have limited English proficiency may struggle to communicate their symptom needs or understand their care plans. So without access to interpreters in all of the palliative care spaces that we work in, or culturally appropriate communication strategies, these patients would face significant barriers to receiving quality care. And then speaking a little bit about communication, I'll highlight that in some cultures, families may request that a terminal diagnosis may not be directly disclosed to a patient, which can create tension with Western medical practices, which prioritize autonomy and informed consent. And similarly, many cultures emphasize collective decision making, which involves not just immediate family, but also extended family members or community members. And Western models often focus on individual decision making, which can create misunderstandings and conflict. So these factors, which I've discussed, underscore the need for more culturally safe and trauma-informed palliative care. To address these inequities, we have to be prepared and equipped as palliative care providers to recognize and respond to the unique needs of racialized patients and families, which includes building trust upstream prior to people accessing palliative care, respecting cultural practices, and providing tailored support to overcome language and systemic barriers. Next slide. These 2 points encapsulate what research tells us about why racial disparities exist in palliative care. And the first statement is really important because it challenges a common assumption that racialized patients prefer more aggressive care at the end of life. And I have actually been told this by many people several times, and I've had to push back against that assumption that people are actually choosing more aggressive care because studies, including research that I've been involved in, suggest that this difference isn't about a preference, but rather it's about inequity. Barriers like mistrust in the healthcare system, poor access to care that is culturally humble and safe, and systemic racism in how care is provided continue to drive these disparities. And the second statement on the screen in front of you is around disparities in communication, which we talked about a little bit on the last slide. And we know how important and central communication is for palliative care. So disparities in communication, whether it's due to implicit bias, language barriers, a lack of cultural understanding, continues to be a major driver of inequitable care. So, for example, racialized patients may not be offered the same options or information as non-racialized patients. The way that that information is communicated may not be culturally safe, which profoundly impacts people's decision-making and care outcomes. And ultimately, these findings remind us that addressing racism in palliative care isn't about changing patients' preferences. It's rather about changing the systems and practices that create these disparities. Next slide. Okay. So this slide talks talks a little bit about grief and bereavement. Grief and bereavement are deeply personal, but systemic barriers often prevent racialized communities from accessing the support they need. Culturally appropriate grief services are usually less common in Canada, which means that families from racialized communities may not see their cultural and spiritual and religious practices reflected or respected. Access to mental health support is another significant issue that I've highlighted on the slide in front of you. And additionally, the lack of representation among grief counselors and therapists can make it even harder for individuals to feel understood and supported during their most vulnerable moments. And these disparities highlight the need for grief and bereavement services that are culturally safe, accessible, and representative. Next slide. Okay. Now, given all of this information that we've discussed so far today, I want to challenge a common assumption that I hear from colleagues and a common assumption that exists in the healthcare system that concepts such as aging, disability, living with a terminal illness, end of life care, death, grief, and bereavement are universal experiences or experienced in the same way across all communities. That could not be further from the truth. And the reality is that these experiences are profoundly shaped by racial, cultural, and ethnic identities. They are not race neutral. So let me explain through a couple of examples once again. When we think about aging and how we care for older adults in our communities, this is very often deeply influenced by our cultural or religious traditions. It can impact our preferences for home care versus long-term care. We know when we're speaking about end of life and death, cultural and religious beliefs play a significant role in how communities approach death and dying. And yet, Western medical systems often fail to accommodate these beliefs, leaving racialized patients and families feeling marginalized. And as I already mentioned, racialized patients are also less likely to receive access to palliative care due to systemic barriers such as mistrust, language challenges, and inequities in referrals. So, as these examples that I provided, and of course there's many more, they demonstrate that race, culture, and ethnicity profoundly shape how individuals and communities experience aging, disability, death, grief, and bereavement. And as healthcare providers, it's crucial to move away from a one-size-fits-all approach, but rather we must recognize the diverse ways in which people navigate these life stages and ensure our systems are equipped to provide culturally safe, equitable, and compassionate care. Next slide. Okay, so now that we've learned about racism and we've talked about racism specifically in the healthcare system, in seniors care, palliative care, and grief and bereavement, how do we define anti-racism? So anti-racism is not a passive stance. It's an active process and a shared responsibility. And I'll start by providing the definitions from a couple of key organizations. The Ontario Anti-Racism Secretariat states that anti-racism is the practice of identifying, challenging, and changing the values, structures, and behaviors that perpetuate systemic racism. And in Nova Scotia, your provincial government has committed to an anti-racism approach through its Office of Equity and Anti-Racism. And they have stated that all Nova Scotians deserve to get healthcare free from discrimination or racism. A framework has been developed which will help to ensure that the province's healthcare is equitable, appropriate, and free from discrimination and barriers to care. In my opinion, these statements from official government organizations should not just be words. They should be calls to action. And as I'll discuss a little bit later on, they should be backed by funding and resources. And at its very core, the work of anti-racism requires action. It's not enough to simply recognize that racism exists, but we must actively work to dismantle it in every aspect of our systems, especially where we work in palliative care, in seniors care, and in grief and bereavement. And this is a shift that we urgently need because this isn't an abstract issue. It's causing real harm to Indigenous, Black, and other racialized communities. And as I've mentioned, study after study shows the devastating impacts of systemic racism. Next slide. Building on the principles of anti-racism, anti-oppression takes a broader approach to addressing systemic inequities. Anti-oppression is about actively challenging the systems of power and privilege that create and maintain inequities. It's not just a theoretical concept, but rather it's a set of strategies, actions, and practices that we can apply in our daily lives and work. And the goal of anti-oppression work is twofold. Number one, it's recognition. So first, we have to start by recognizing the various forms of oppression and discrimination that exist in our society. So these include all of the isms that we've discussed, such as racism, but it would also include sexism, ableism, ageism, transphobia, homophobia, and others. And each one of these operates in unique ways, but shares a common root in systemic inequity. And number two, the second goal is action. So like anti-racism, anti-oppression isn't passive. It's about actively working to mitigate oppression's effects and eventually aiming to equalize the power imbalance in our communities. And this work is critical in healthcare, especially in palliative care, where systemic inequities profoundly shape patient and family experiences. Next slide. Okay, so how can we take awareness to action? And what are some of the key practical takeaways? And I'm going to talk actually about 7 key practical takeaways. Next slide. Okay, so number 1, treating people differently depending on their needs. This graphic and this concept represents a foundational principle in anti-oppression and health equity work, treating people differently according to their needs. And often, we might think of fairness as treating everyone the same, but equality, providing the same resources or opportunities to everyone, doesn't address the systemic barriers that people face. And instead, equity focuses on recognizing and responding to individual needs. It's about removing barriers and ensuring that everyone has the support they require to achieve equitable outcomes. And I'll provide you 2 simple yet practical examples that you might be able to relate to. So, for example, a patient who is unable to speak English would need an interpreter to fully understand their diagnosis and their treatment options, and for them to be a participant in their care. Having access to interpretation services and providing that patient with that access isn't giving them an advantage. It's rather leveling the playing field so that they can access the same quality of care as everyone else. Similarly, a patient who is unhoused would require additional support in order to be able to access housing as part of their plan, whether they're receiving a palliative care approach or not. And that extra effort would ensure that their care is equitable and not just equal. So this illustration you can see in front of you on the slide is about equity and intersectionality, and often the blindness to the factors that influence and often the blindness to the factors that influence it. So how can we help people to actually overcome some of those hurdles on the right-hand side of this picture in order to achieve equality? Once again, it's via equity, treating people differently according to their personalized needs due to systemic and individual circumstances to actually achieve equality and justice. So I actually would ask you to pause at this moment and ask, when you're seeing a specific patient, do you ask yourself, what does this particular individual need to do well? And what do they need? What do they require in order to thrive? And more importantly, how can we adjust our systems, policies, and practices to meet those needs? Next slide. Okay, so here's key takeaway number 2, which is about advocating and amplifying marginalized voices. So firstly, we have to stop tolerating injustice. A lot of discrimination, racism, and oppression persists because it goes unchallenged. And what this means is no longer accepting the status quo or excusing inequities as just how things are or just how we've always done things. And in your role, especially if you're a healthcare leader, this might look like identifying it might look like actually taking out time to identify discriminatory practices and policies or systems and starting to take a stand against them. And this is kind of the first step here, to recognize and to refuse to accept injustice wherever you see it. As you can see on the slide here, it's also about speaking out against all forms of discrimination and oppression. And this work does require courage, because it's about actively calling out racism, whether it's overt or covert, whether it's systemic or interpersonal. So this includes speaking up when you witness microaggressions, but also speaking out against biased policies in your workplace or community, being that consistent advocate for equity and inclusion, even when it feels uncomfortable. And remember, we talked a little bit about the concept of privilege. Privilege isn't inherently bad, but it's rather what we do with it that matters. So whether it's racial privilege, economic privilege, educational privilege, it's important that we leverage it to amplify the voices of those who are often ignored or marginalized. This could mean advocating for policy changes, creating inclusive spaces in healthcare, or simply standing beside colleagues and supporting colleagues and community members who are speaking out. So I want you to ask yourself once again, what can I do in my daily life to contribute to this movement? Where can I make the most impact? And I want you to remember that the work does start with us. Next slide. Okay. So number 3 is about implementing a trauma-informed approach. And trauma-informed care is a cornerstone of equitable healthcare. It involves recognizing the profound impact of trauma on individuals, especially those from racialized communities who may experience systemic oppression or intergenerational trauma. It involves reinforcing trauma-informed practices, ensuring that the care we provide prioritizes safety, choice, and empowerment for individuals. It involves a reframing of the quote unquote difficult patient, because a so called difficult patient or family member would very often be someone who is navigating trauma or systemic inequities. It's more important that we approach these situations with empathy, with compassion, and understanding. It also, once again, requires us to identify and confront normalized racist ideas embedded in our institutional policies and practices. And you can ask whether your organization is doing work around trauma-informed care and how it's building capacity for the people working in the organization to provide trauma-informed care. And these approaches and implementing the trauma-informed approach not only starts to address disparities, but also fosters trust and safety, especially for patients who may already feel marginalized by the healthcare system. Next slide. Okay. So this point, learning by centering marginalized voices, might sound simple in principle, but it's actually very profound in practice. And if we truly want to provide culturally safe and culturally humble care, we need to shift whose voices we center when we learn and when we lead. And this means going beyond academic journals or traditional clinical guidelines. We must also learn from the lived experiences of patients and care partners and communities who have encountered racism in the healthcare system. We must learn from the stories of communities who have long been excluded or harmed by institutional care or by the healthcare system. And we have to acknowledge and learn from the wisdom embedded in non-Western ways of knowing and communicating, whether that's indigenous worldviews or different cultural perspectives on healing, on death, and on grief and bereavement. And even thinking about academic knowledge with respect to palliative care, we need to ask this question. Well, who gets to produce knowledge? Who is missing from the textbooks, the research articles, the research teams, and the leadership tables? When we start to center marginalized voices, we challenge the default and we open the door to more compassionate, more just, and ultimately more effective care. Next slide. So point number 5 is about assessing and measuring systemic change. We cannot address inequities without data. Here in Canada, unfortunately, we don't collect race-based data. We often collect other surrogate measures, such as country of birth or the language that people speak. But being able to collect equity-oriented data, including race-based data, helps us identify disparities and measure progress and do this important work. And at the same time, we also must examine policies within our organization, including hiring, training, and other institutional practices to ensure that they promote equity rather than perpetuate inequities. Next slide. So point number 6 is about improving access and creating inclusive spaces. So equity in care requires addressing barriers like language. And we've spoken already about how when people receive language concordant care, of course, their healthcare outcomes would be better. It also involves us questioning how our institutions accommodate the specific needs of racialized peoples. And if we make our healthcare organizations and facilities more inclusive, this would demonstrate respect for this would demonstrate respect for diverse cultural and spiritual practices. Next slide. Okay, and the last point, the last key takeaway, number 7, is about decentralizing power for community-led solutions. So true equity involves shifting power and resources to marginalized communities, and community-led approaches are more effective because they have more buy-in. Rather than doing things to people, we should be doing things with people and we should be working together with communities. grounding our changes in the lived experiences of these communities and directly addressing systemic barriers. And supporting these initiatives is essential for sustainable change. So, to summarize, these 7 key takeaways are really the steps that we can take to promote anti-racism and anti-oppression in healthcare. By addressing education, accountability, access, and power, we can create systems that truly serve everyone equitably. Next slide. Okay. So I want to let you know that this work of anti-racism is not something that we can address with a one-time training or a single policy change, but rather it's a lifelong process that demands consistent effort, self-reflection, and action. I encourage you to think of this as an iterative process, which can be viewed with a quality improvement lens. And I'm assuming that in many of your organizations, you must already have quality improvement plans, and you can think about including very important health equity measurements in those quality improvement plans. But this work requires a daily commitment to challenging biases, examining systems, and creating more equitable practices in our work and lives. And the commitment alone, I will say, is not enough. It requires funding, and resources have to be allocated to ensure education, data collection, community-led initiatives, and systemic change is adequately supported. Additionally, there has to be prioritization from leadership and government. Leadership within organizations has to not just endorse this work, but actively lead it by modeling anti-racist behaviors, holding institutions accountable, and embedding equity into every decision and strategy. At the same time, governments also play a critical role here. Policies and funding decisions at the provincial and national levels must align with anti-racist principles, addressing systemic barriers and supporting initiatives that promote further equity in healthcare and beyond. So this process, once again, is ongoing, but it's also deeply rewarding. It's about creating systems that are fairer, more compassionate, and more inclusive for everyone. Next slide. Okay, so I really wanted to emphasize how important it is for us to continue this work, and I'm so happy that this is a focus of this conference. And I'll just share that, as we know, the political landscape is shifting, especially in the US, but to some extent, in my opinion, in Canada as well. And we are seeing a growing backlash against equity, diversity, and inclusion work. And one only has to look at some of the very sad and horrific headlines from the US about DEI or woke ideology. And while those headlines might feel far away because they're not really in our country as much, these narratives are starting to seep into the Canadian discourse as well. But I want to be clear with all of you, our focus on health equity is not partisan, but rather it's ethical. It's rooted in human rights, where we truly should believe that every person deserves to receive care with dignity, respect, and cultural safety, regardless of who they are, where they come from, or what community they belong to. And healthcare, including palliative care, is a right and not a privilege. In moments like this, we have to ask ourselves, will we back down or will we double down on our commitment to human rights, dignity, and equity in care? Let me be clear. We cannot, we must not, and we will not lose our focus on equity, diversity, and inclusion. I do not consider this work optional, but rather I think of it as core to our mission as healthcare professionals and essential to who we are as stewards of care, compassion, and justice. Next slide. So in the face of all of this, what are some examples of what we can actually do? So I want to take a moment to share a few examples of how I've tried to contribute to health equity in my work, always in partnership with others and always as part of something bigger than myself, working together with a team. And as we've discussed, this work requires ongoing commitment, collaboration, and action. So the slide in front of you highlights some of the work that I've been fortunate to contribute to in this space, which includes research and published papers on cultural safety and anti-racism. And this research explores how healthcare systems, including palliative care, can better integrate culturally safe, trauma-informed practices. I've developed and led workshops on health equity, which are usually interactive sessions designed to empower clinicians and organizations to embed equity into their daily life, into their practices, into their organizational framework and policies. I've created accessible e-modules to build knowledge and capacity for cultural humility and anti-racism. And I've also, actually, I'll share in my hospital, we're currently working on our 10-year strategic plan, and I'm leading the pillar on health equity as well. And I will emphasize again that these projects are not about individual efforts, but rather they're about engaging communities, sharing knowledge, and collectively driving change. So I invite you to join this discussion, to join this work, whether it's through collaboration, starting to think about and applying these principles in your own work, or sharing your own experiences and insights. Together, we can continue to learn, innovate, and advocate for a more equitable future. The next slide. Okay, so I would like to leave you with this quote by James Baldwin that encapsulates the spirit of this work. Not everything that is faced can be changed, but nothing can be changed until it is faced. This quote reminds us that while the path ahead may seem daunting, the first step is always to face the issue head on. And by doing so, we can we can start to open the door to the possibility of change and progress. Next slide. Okay, thank you so much for having me. I'm truly grateful to all of you, especially to Tim Guest and Beth Lynch and everyone at the Nova Scotia Hospice and Palliative Care Association. Thank you very much, Jordan, for doing a great job with navigating the slides and moving back and forth with the Slido polls. I'm really grateful to all of the organizers of this year's conference and to every one of you who is doing this hard work each and every day. Together, let's aim to create a future rooted in equity, justice, and compassion. Thank you.
Thank you so much, Dr. Arya. Wow. So your talk was, I had written things down, but I'm just going to say like inspiring and powerful. And I love the 7 steps, and I love that you laid out for us the issues, but also gave us some things that we can do. And I'm sure many people in this room are already doing a lot of the work that you've talked about. But it is empowering to know that there are things we can do. It's not just a matter of understanding what the issue is, but it's also what we can do to help change the way things are in our healthcare systems. We're supposed to have a break, but I feel like there's going to be people who would like to comment, and so I'm wondering we'll just maybe push the break out a few minutes and give people the opportunity. If anyone would like to ask a question of Dr. Arya or comment on the presentation, please go ahead and step up to the mic.
Hi, can you guys hear me?
Yeah.
My name is Chrissy, and I just want to self-identify that I'm a mixed race person, but I'm white passing. So I'm also a social worker. So something I continue to encounter in my work, particularly in large organizations, is even though we have DEI as a stepping stone, something we're trying to do, whenever I call out anything, there is a resistance and a discomfort and sometimes a backlash. And because I'm white passing, I often am privy to conversations that would not happen in a room with BIPOC people present. And when I drop the hammer that I'm mixed race, I come from a Muslim family, there's just this discomfort is there. So I'm wondering if you have any advice or comments for people in the room who are white, who don't necessarily understand the implications of being BIPOC and the daily microaggressions and those small impacts. So I just wonder if you have advice for people to think about as they carry on in their journey supporting DEI.
Yeah, thank you so much for that great question. I really think it depends on the state of your organization and how supported you feel. As I mentioned, this work is really only possible when you have a team that's supporting you, and hopefully when you have funding and time and resources that are provided that are provided to you from leadership. So I just wanted to emphasize that. At the same time, I will say that part of this work is about learning and growing together, as I emphasized in the beginning. And I think, it is important for everyone, whether you're white or you belong to, another community as well, that we all kind of acknowledge where our starting point is and committing to learning and growing together. So that's really all I would say. And I can really think about broadening out this group and share some examples that might be applicable to different people at different levels. So I've seen that people will, for example, just take it upon themselves to read books around anti-racism and anti-oppression work, or the history of racism in healthcare, and I provided some examples about that. And that's a reasonable starting point for many people. For other people, it might be actually about challenging some of these policies that exist in their organization. For other people, it might be doing research, might be thinking about quality improvement plans. But once again, I will say to you that based on at least some of the initial information you shared, sometimes it's hard to be that only person who's trying to advocate for change. So you do need, I would definitely recommend that you try to work towards a strategy where you can have buy-in from leadership.
Thank you so much. I appreciate it.
That's a tough question that you asked, and thank you for sharing it and for being vulnerable with us. Any other comments or questions? I know the MC always says I'm standing between you and your coffee or your bathroom break. I had a quick question. The e-learning course that you talked about, is that free, and how do people access it?
Yeah, absolutely. I can just share some details about it. So it's a course that I led the development of with an organization that's called the Ontario Centres for Learning, Research and Innovation in Long-Term Care, or Ontario CLRI. So perhaps in the chat, I can put their website where you could look. They have a whole host of resources on health equity, which are tailored for long-term care. And that course is free from my knowledge. And I'll just share with everyone, which is, I think something inspiring for me is that when we designed this course, it was, our target was that 70 people would actually take it. But there's been so much interest in learning about this work, even in the long-term care sector, whereas we can all imagine things are stretched, that over 2,500 people have actually taken that course. But I'll put it in the chat here, and perhaps somebody can share some of those links as well with the other attendees.
Great, thank you so much. All right, well, thank you so much for your talk and for inspiring this really important conversation. And I have no doubt that what you've shared with us will continue to grow, and we're in it with you for sure. So thank you so much.
Thank you, everyone.
All right, so we are